and there is still work done to push that through. But what essentially that is to get Georgia to recognize, professionally recognize direct entry to traditional or community midwifery as a practice to help birthing families here in the state. Right now, we are seeing where Black maternal mortality is at the highest it's been. However, I like to keep in mind that Black maternal mortality in the state of Georgia has been ridiculously high for the last 35 years. So there's something that has to give in that regard. And one remedy that was presented was HB 267, the Certified Community Midwives Act. I am also a state of Georgia legislative organizer, working with Center for Common Ground as the leader of the Central Georgia Democracy Center. And I am also the Henry County Democratic Committee representative for District 3. So a lot of our work here, or a lot of my work, if you will, here is to make our state more progressive. That's the nice way of saying it, I guess. More progressive as we work to make healthcare affordable and accessible by all. Maternal mortality rates increase for Black women by 30% when you move into the rural areas of Georgia, and it increased by 50% for white women when moving into rural areas as well. And that we cannot simply allow that to continue to be the narrative for the great state of Georgia. So I thank you for having me on this discussion.
Lode, you're amazing. Thank you so much. And I'm so proud to be a partner with you in the work at Center for Common Ground, and the work that you do in the midwifery world is amazing. So thank you. We're honored to have you. So why don't we have Simran come up and introduce herself, and then we'll throw it back to you, Lode, and then let's just have a conversation here about what's the reality of our situation with regard to reproductive rights, and how explicit do we need to be? I mean, in particular, this is a debate happening internally. How explicit do we need to be in terms of our legislative language about this conversation? So Simran, why don't you come up and introduce yourself, and then we'll bounce it back to Lode, and then you pick it back up. Simran?
Hi, everybody. I'm Simran. Thank you all for having me. I'm a third-year medical student at Stony Brook University School of Medicine. I decided to become a physician partly because I'm a huge nerd for medicine and the human body and anatomy and physiology, but also because healthcare to me is fundamentally a social justice issue, and I wanted to be in a place where I could advocate for my patients and in a place where I could hopefully make change. As a woman of color, I find people are more willing to listen to you if you have some letters next to your name, unfortunately, and MD did give me a little bit of clout, I guess you could say. Prior to medical school, I worked as an AmeriCorps volunteer trying to get medication for people who can't access it due to lack of insurance. And at school, I'm involved with our student-run free clinic, and I'm constantly reminded of how our healthcare system fails patients. Specifically, I've always had an interest in women's health particularly, and I'm choosing to pursue a career in OBGYN. And yeah, that's kind of me. Oh, and also I'm involved with PNHP, which is where some more advocacy work comes in. So yeah, thank you for having me.
Right. Yeah. Hey, thanks so much for being with us, Simran. And it'd be great to have both you here on the screen, I think, at the same time. For those who don't know, PNHP, Physicians for National Health Program, advocates for what's called single payer, Medicare for all, universal health care, all the same idea. And so that's the thrust of the work that we do. But this conversation about reproductive rights and also healthcare for the trans community in particular is something that's being offered up as possible language for this legislation. And the legislation was known as, it was HR 3775 from the last Congress. It's a state-based Universal Healthcare Act, and the bill will be reintroduced sometime in April, as we're understanding, and that we'll want to get as many members of Congress to sign on with that legislation. But right now, the conversation is, what should the wording of the language be in particular? And so this is a great opportunity to have this conversation here with you both, Lode and Simran. So Lode, do you want to carry this conversation a little deeper into the question of why it is? I think somebody's muted or unmuted. Can folks mute themselves? I think it might be, is it, I'm seeing.
Ruth, you need to mute yourself, Ruth.
Ruth. Yeah, thanks, Ruth. Okay, yeah, folks, if you could remain muted until we come into a little bit of question and answer period, that'd be great, just so there's not background noise. But just why, Lode, and then Simran, why is it so important that we be intentional, that we be explicit, that we be forthright in discussing reproductive rights in all spheres, and in particular the political sphere in Congress? Lode, do you want to take that question?
Yes, I will say that, excuse me one moment. There we go. I will say that as an epidemiologist, one thing that I have learned and maintained in my training and in my work is that in order to advocate for a thing, you must advocate for that thing specifically, right? So you must be as explicit as possible when writing legislation, but also inclusive, right? So one thing that we have discovered, or one thing that we've had to overcome, was how do you explicitly advocate for the Black community while also being inclusive, right? So one thing, if we're going to use the stats or the data, if we're going to use those numbers to invoke an emotional response, right? Because that's how we get the boots on the ground in support of whatever legislation. If we're going to do that, then yes, you use the data to invoke that emotion. However, within that legislation, you speak specifically to whatever group. So if the group is, if we're working for healthcare for all or Medicaid for all, then we must maintain how will these, each group be affected, or how will each group be benefited. So yes, explicitly, I'm talking down to the last detail, the most finest detail. Within the state of Georgia, that has presented to be a problem for us because we deal with high amounts of racism and high amounts of sexism. That's the great state of Georgia. So we're looking now to hold our legislators accountable, because if we're voting you in to do a thing, you must in turn do that thing, or you will not get this vote again. That's where we're left at here in Georgia. Is not the most effective, but it is proving to push us forward. With racism being so high, and when I say racism, I think racism is a dated term, but when you have instances where 63% of all Black maternal mortality is preventable, you have to look at why. What is the common denominator? It's not just, oh, they don't have access to healthcare or they're impoverished. That's not just it when it comes down to if your physician just does not listen to you. They don't believe you when you are speaking. And that's what Black and Brown and Indigenous women are dealing with. So yes, explicitness is most definitely important, especially if that's the cause of it. My reproductive justice data analysis from 2019 to 2021 is one of the pieces of research that's spearheaded, for medical providers to check their bias. So if it is the bias that got us in, if it's the benign neglect that got us into the condition, we're going to have to be just as explicit to get us out of it.
Terrific. Thank you, Lode. This is very powerful. Thank you for your response. Simran, thoughts to add to that notion of being very specific, very explicit, very intentional in our use of language in defining what it is that this legislation should provide? Simran?
I have to admit, I personally feel a lot of ambivalence around how specific to be. Um, because based off of discussions I've been privy to in the past, I find that not the term reproductive health so much, but the term abortion specifically is very polarizing. And I don't love the idea of that stopping the single payer conversation in its tracks with a person who might be otherwise open or amenable to discussion. That being said, I hear what Lode is saying about needing to be explicit and needing to advocate for things, because if you don't ask, you'll never get it. So yeah, I feel like that's very unhelpful, but I feel a significant degree of ambivalence around the issue.
Yeah,
I will say, I will add to that, and to your point, Simeon, did I pronounce that correctly? Simran.
Yeah.
Thank you. I will add to that, in the advocacy, there are some things, because we find that we have to reach across the aisle. This is where the bipartisanship comes in at. What will, again, trigger someone? So we don't want to trigger any folk. However, we do want to make sure that when we're speaking the data, and the data doesn't have to speak on abortion specifically, but the resolve can speak on abortion without speaking on it, if you will.
yeah, thank you for that. This is the debate that's going on in our circles right now. Is we all support in principle what it is that is being explicitly stated, but how do we advance this politically? And that's the question that is on the table right now. So just to set the context for folks, if you know, the United States House of Representatives, the lower chamber of Congress, is controlled right now by the Republicans, and Congressman Ro Khanna, this is his legislation. This is a bill that has been carried for several years now, and it's designed to enable individual states to go forward in creating universal healthcare systems. He's come back to us and said, let's be explicit potentially. So this is the discussion's continuing. So your ideas here are very important for us to ponder and to think about. But do we just stop at reproductive rights, or do we go explicitly and say abortion and gender affirming care, you know, for the trans community in particular? And that's really what's being debated and discussed at this point. And so we're not all in agreement, and that's why what you have to say here is so important for us to be thinking about and pondering. So there's sort of the principal question, and then there's the political question. So in your own realm, in the work that you do, are you how do you navigate the worlds in which you operate? It would be helpful for us to understand, as your audiences vary. I mean, here you are before a predominantly white, older, mostly medical professional, retired audience. How do you frame your discussions? Do you change your words? Do you solicit input from people as you go forward? So I think it would be helpful just to get an understanding as to how you go forward in your conversations that you have about these very powerful conversations around reproductive rights. So why don't let's start with you this time, Simran. Why don't you, how is it that you, as a woman of color in particular, carry yourself in these conversations with varying audiences?
You know, it's funny when you bring up that question. I actually immediately think of my father, because I come from a culture that's relatively conservative in those matters. And how do I have a conversation with people of that background, or who are coming from that place, in a way that's respectful but still gets my point across? And it's tough. I think like a lot of it is just like keep your cool, unfortunately. Like it's a very emotional issue and you shouldn't have to keep your cool if that's the emotions that you're having. But I find unfortunately that like you're more liable to push somebody away than get them to agree with you if you come with too much emotion or aggression. And also like I suppose like saying back what they're saying, but not in a way that's could be mistaken for combative, just in a way that shows that you're listening. And then kind of building off of that, but not agreeing. I hope that's not too vague. If you have like follow-up questions, happy to address them. Yeah.
Yeah, so maybe try to identify some common ground and then build from that, maybe. Yeah,
Yeah, but I'd be lying if I said like I don't like. Let's say it's not my father. Let's say it's just a like a attending, an older white male attending. Like there's power structure there, right? I cannot say what I'm really feeling in that moment because it's like, oh, this man is gonna write my evaluation. If you don't know, like that goes into your grade as a medical student. So like kind of in the moment, you're like, okay, whatever. And then afterwards you like scream into a pillow and like vent to your friends. But like unfortunately, yeah, there are power structures that sometimes prevent you from being totally forthright and fully expressing your emotions.
yeah. Thank you for that, Simran. And just to add for Lode and you, Simran, because the Democrats are in the minority in the U.S. House of Representatives, this bill may take a different shape, more like a messaging bill, as opposed to a bill that has a prospect of being passed this Congress, right? Because we don't really have a realistic chance of getting it through this Congress. Maybe in 2025, if the Democrats take back the majority. But right now, the question is, what's the best way forward in advancing this discussion? So with that, Lode, I mean, how do you navigate the waters in which you tread? How do you frame your discussions given a different audience as you present yourself? Lode?
Man, and that is that's a delicate peach right there. I would say that I tend to rely on the data. If 40% of Black families are not covered by Medicaid, and it would actually be cheaper to expand Medicaid in the state of Georgia, then that's what I go with. We stick to the data. Yes, it can invoke emotions, but what I find is that for the person that is standing on the research, that is standing on the facts or the truth, they tend to be less emotionally involved than the person that's receiving it. So that's the issue that we tend to deal with when we have some of our more conservative family members or people in the state. It's some things that they just do not want to hear. And we're at a point now we're at like, I guess, a crux that it does not matter if you want to hear it. This is what it is. And it is time for us to move forward in a more healthy way to get more people covered to, I totally hear Simran, because again, if we're speaking on abortion, the majority of rural Georgia is staunch religious. That's why they vote the way they vote. It has nothing to do with equality. It has very little to do with racism in that regard too, because now they're just speaking on principalities of their religion. But at the same time, that is not this, we're not in that same place. 100 years ago, okay, I get it. 2023, you're talking about your children, your grandchildren, and your grandchildren's children. What type of environment are you leaving them when they're not able to access, Medicare? They can't afford health insurance. They cannot afford a non-biased, culturally inclusive provider. We sometimes I believe that it's up to us to leave it on their plate. If we are people of moral, and if we're going to rely on our moral indicators, then this is a moral issue. And then it makes us more responsible to handle it and address it accordingly. So again, I like to rely on the data. I'm a I'm not going to say I enjoy a little bit of confrontation, but that's why I'm here. We have to let the cookies crumble. We can, bandage our bruises and come back the next day prepared to advance this movement forward. I will say that most of the time in my work, it is not the elder white men conservatives that we run into issue. We run into issues more so with Black people that want to uphold white ideology. And white people are more receptive to what we're saying. We all of this and the clashing, just like in again, using Georgia as an example, we have the Black Caucus here. It's the Black Caucus that gave us the first closed door to say, hey, it's racism. You're in the South. What can we do? That's something that we expected to hear from white representatives or conservative representatives, if you will. We don't hear that from them. We hear that from the representatives that we voted into office to actually do the work for their community. So I think it should be approached, as Simran said, leaving emotions at the door, keeping your cool, but at the same time, you cannot forget about the people that you are advocating for. Because once you allow, an opposing factor that may not be true, simply because you're conservative, simply because you did not live this experience, simply because you can't personally identify with it, doesn't mean that this is not what's happening. So the more we allow that to fester, the more we allow that to continue, the more harm it does. I also agree that we should be explicit, simply because when we're not explicit, what we see in legislation is that it creates a stalemate. It creates a nothing burger for the community that you've gone to advocate for. It creates just a study group. Georgia is notorious for studying things to no end, to no resolve. It's ineffective. Much of our issues here in Georgia is ineffective leadership. Georgia doesn't suffer from money, having, lack of finances. We don't suffer from there's no lack here. We just have ineffective leadership. So when we are not allowed to call a thing, or if we're not willing to advocate for those that need the advocacy, those that cannot raise their voice, those that are not able to be in these discussions, it sends us off our target.
Wow. Thank you. Really powerful. Why don't we open up for just a few minutes of Q&A? Folks have questions for Lode, Simran, if you could, just throw up your hand. We'll go about 10 minutes and then we'll bring up Barbara for our state reports on the back end. Let's see, Tom Sensick, Lynn Heidekoper, Bob Mason. If you could make your question or comment very brief, and then we'll be able to get more folks involved. Tom?
Mine will be very brief. I want to put the language in the chat from our values of Senate Bill 770, which is very explicit. We went with explicit language in Oregon, and the courage to have conversations, I think, is very important. So I'll just put that line, I'll cut and paste and put it in the chat. People can read it. It covers all the details of where we want to go with access to healthcare. So thank you. This is very important to me. And the fight is on. I fought for birth control in high schools here. And because we were able to have those conversations, we eventually got them, and the conversation changed over time. So thank you.
Thank you for your work, your leadership in Oregon. Lynn Heidekoper?
Yes, Lode, can you tell me what your state legislature, the two houses, how many Democrats and Republicans, what is the balance?
That is a great question. I will have to get that, because I do not want to mess up the numbers. So I don't want to give you a quote and I'm messing up the numbers. But right now, the Republicans are in the majority. Of course, our governor is Republican, and that's why he's able to do what he's able to do in office. Right now, we are seeing the highest rate of hospital closures. The governor actually has his own healthcare pathways program, but it would be more expensive and cover less people. So, and he's made it, he's been quite frank about not accepting any federal funding, as well as not expanding Medicaid. That is not on his to-do. This is why he chose, or he's choosing to move forward with his Pathways program, and it costing more to the state and also covering less people.
The reason I asked that, I was surprised that you said your bill for midwifery has not passed. That doesn't seem to me to be a partisan issue. How long has the bill been in existence, and where are the stumbling blocks?
The stumbling blocks is in the language. So as the person, I did my organization, FTC Charity, we did the research for this. And what I was told, it was that it's too radical. So it speaks specifically to those numbers, but this is why we can't get it passed, because we're looking at ways to include everyone, but it's not maintaining specific, what is the word I'm looking for? It's not maintaining a focus, if you will. So the bill was written in 2019. Since then, they've gone to HB 111 as well, HB 215. They're attempting to remodel, revamp that legislation, but the issue that they're having is they want it to be something inclusive, but it's not. When you look at the data, and this is data from Mercer University, is data from Harvard, is data from the CDC, is data from the Maternal Health Task Force. When you look at these numbers, you are looking at Black women dying 243% more than white women. And the next category of that is Hispanic women, and their rates are still down in the single digits. So you're comparing apples to oranges to make it inclusive. But what we're finding here is that the community is they're not getting community support to back the bill once it's made inclusive. Because again, it turns into, we pull on the heartstrings and we say Black women are dying. And then when money is released, the money does not go to the Black community. It goes to every community that was included. So the community is not backing that. The state is having a hard time getting the proper language. We saw it as a bipartisan issue because, again, in the metropolitan area, once you take Black women out of metropolitan areas and put them in rural areas, their maternal mortality rates increase by 30%. But it's also the same and more damning for white women. When white women move out of the metropolitan areas, their maternal mortality rates increase by 50% when you move to Georgia. So we see this as something that we have a common denominator here. While there are two different causes for maternal mortality, with Black women, it's hypertensive disorders. With white women, it's more so drug usage. But that's what we're finding in these rural areas. And this has been confirmed by, again, Mercer. It's been confirmed by Harvard. The toxiconomy reports is showing, the CDC even says it. But the issue is they're not finding the language that's getting people to support it.
Wow. Thank you, Lode, and thanks, Lynn, for your question. Yeah, that is quite a challenge that you face there, Lode. Let's see, we've got 4 folks in the queue right now: Bob, Tom, Sam, Marissa Bell. I'm trying to think of how we negotiate the remaining time that we have. We try to finish this at the top of the hour. And do you have time beyond the hour, Lode and Simran,
Yes.
if we spill over a little bit? Okay. And Barbara, I know we were going to have a state report from you, state's report. Barbara, how's your time? Barbara Pearson? Barbara?
I'm flexible for about 15 more minutes.
From now or 15 minutes after
From
the
after the from after the hour.
Okay.
Till about 4.
Okay.
And
So
I don't
we'll
have to
take,
do it.
why don't we, we'll take this, the folks who are in the queue right now, we'll work with these questions and then we'll bring you up, Barbara. And again, if you can keep your questions and comments short, appreciate it. Bob, then Tom, Sam, and Marissa Bell. Bob?
So thank you, Lode and Simran, for your presentations today. And I don't want to necessarily put you on the spot, so you can certainly defer from answering this question. But as part of the group that's meeting with Representative Khanna's office, what I'm focused on is whether or not we should support the current language in the draft legislation, which is explicit about covering abortion and gender affirming care, even though we know that is going to trigger or even more polarize some people, or do we simply recommend that reproductive care be the phrase? And I'm really thinking that women and people who can become pregnant are the voices that we should hear from. But this is a question not only of principle, but also of what is strategically most effective. So I'd be interested, Simran and Lode, if you feel comfortable answering what you think.
Do you want to take it, Sarah?
I can speak after you if you like. Yeah, you go first.
I simply would say that staying the course of reproductive justice or reproductive wellness, something like that, is more inclusive and more gentle, if you will. It's also effective because the term reproductive justice, which was coined or created by a nonprofit Sister Song, they are a reproductive justice organization. The definition is that birthing people, birthing family, birthing folk, however, women, however we're going to title it, they have the right to have or to choose not to have children, as well as raise those children in a safe environment. So it includes everyone. It's an inclusive statement, while at the same time being very specific. So we're including everyone that has the ability to have children, however they choose to have children, as well as those that choose not to have children. That's what reproductive justice is as well, choosing not to have children. So this is how we can tackle that abortion term, as well as transgender or, excuse my inability to be politically correct at this time, but this is how we can include abortion and the transgender community without necessarily triggering those that are more conservative. That anyone that chooses or anyone that is able to have a child, they have that right. It's a reproductive right. They have the right to choose to have children, to choose not to have children, and to raise those children in safe environments.
Thank you. Brilliant. Thank you so much, Lode. Simran, any thoughts?
Yeah, for me, that was amazing. I think also just from a political perspective, I think using the term reproductive health is less likely to shut down any conversations about single payer healthcare.
Okay, thanks, Simran. Let's bring up Tom Gottlieb. Tom?
Yes, thank you so much for this presentation. And as a practicing physician, I had a slightly different approach, which really brings out the conflict. Data and science, to my mind, in the absence of ethics and morals, is empty. And the two must come together. And now we're discussing the rights in addition to ethics and morals around racism, around religion, in addition to the ethics of physicians. And just in brief, the ethics of physicians is do good things, don't do bad things, justice, and finally, patient autonomy. And that really relates to the previous message that we had gotten, that we really need to listen to, to the patients and what they want. And that's the struggle that we had in the medical field, not just physicians, but nurses and midwives, et cetera. So I wonder if you could respond to that, as that being my focus, and is that helpful?
Simran, Lode? Thoughts?
Yes, I was yielding the floor in case Simran had wanted to get on.
Yeah, no, I agree. Like essentially the question is, this is a question about ethics and what is the role of a healthcare provider. And a big part of that role is listening to your patients. Is just reiterating what was said and totally agree. Yeah, there's beneficence, there's autonomy, and there's paternalism, which we're moving away from now, I think, in the healthcare model, in favor of a more patient-centered way of going about healthcare. So I agree.
I would like to add to that, in the research, one phrase that I was a bit triggered. I'm thankful that it received such, it caused such the change where we started to hear physicians say, I'm going to check my bias, or we need to check our bias. I don't think that is enough, because again, if we could trust that you could check your bias, when this mother said she's in pain and she's never felt that way, something would have went off and you would have checked it then. So in this, when we're talking, speaking about ethics, speaking about racism, this is something that has to be unlearned, because for many years, it has been taught that Black people don't feel pain, or they have a higher pain tolerance, or they're born drug addicts. These are things that, especially here in the state of Georgia, it has been taught. You talk about the father of gynecology, that happened here, where all those heinous, we know. So again, I think there has to be, and this is where the uncomfortability comes in at, because the people that sit in the seats up high do not want to feel that they are being being forced to be made accountable for the wrongs that have been done, but we're here for a reason. But I think that, I agree, it has to be addressed, because again, if the ethics were there, if the morality was there, we wouldn't be here in the first place. Racism and sexism is the thing that they're threatening public health, and it's literally killing the public. Again, when you have 63% of maternal mortalities are simply preventable, you have families losing children, you have children losing mothers, sisters losing siblings for no reason, simply because a physician felt as though his or her ego was more important. It's delicate. It's very delicate and it's uncomfortable, but it has to be done.
Thank you. Thank you, Lode, Simran, Tom. Sam Metz.
Thank you. I'd like to riff on something that Simran brought up. I'm a local single payer advocate. Every night I sleep with a local abortion rights advocate. It's the same woman every night, by the way. My son and his partner are both gay trans males, so our social justice consciousness is high. My wife and I both know abortion rights advocates who are not comfortable with single payer. And I know there are single payer advocates who are not comfortable spending tax dollars on abortion. I suspect this reflects the population in Congress. If that is true, then our two movements, abortion rights and single payer, are more likely to succeed in a congressional vote separately than as a single issue, or requiring unqualified buy-in to both abortion rights and single payer simultaneously. Does this make sense from a political standpoint?
Simran, you want to start on this one?
I don't know if I can speak to a political standpoint, but I agree with what you're saying. I actually came to that conclusion to myself, that these are two battles in the war for health equity that can be fought on separate fronts. so to speak, and might be more successful being fought on separate fronts.
Lode?
I definitely agree with that. I wanted to speak on the language. I think that would come down to that language, maybe not reproductive justice, but reproductive care even, to be more inclusive. Again, I feel that in being explicit, you be explicit with the data and then inclusive with the language. So it's difficult, but I agree that if we had both sides coming at it with different approaches, or multiple sides coming at it with different approaches, it would be more successful. Yes.
So reproductive care, it would be your chosen frame? Is that correct?
Not my chosen. I would definitely stick to reproductive justice, simply
Justice.
because that is something that's we've learned is acceptable here in Georgia. So even with the more religious base, with the more conservative base, when we postcard, when we phone bank, they are more receptive and accepting of reproductive justice. I will say that it allows for more discussion, because when we're in rural areas, many of the white women, they vote how their husband votes, and that's either by religion or by force. We have plenty of videos where husbands are standing outside of the booth like, you better vote how I told you to. So it also brings up that dynamic where you have one part of society that's trying to push for more progressive legislation, and then you hear a narrative saying, you know, white women vote against their better interests. Me being in Georgia, they vote for their better interests. If you're left in rural Georgia out in the middle of nowhere where you cannot, it takes about maybe 45 minutes for police to respond, 45 minutes for firefighters to respond, you are thinking of your safety. That's first and foremost. And I don't want to paint this as a battered, domestic violence, but we've seen what we've seen here. So I will say that even in having discussions with them, even getting those women to share their birth stories about how they felt that they were not heard, about how they felt that when they came home, they didn't have care, they didn't have proper support, that opens the door. So even in the most conservative states, reproductive justice has been received well, I should say.
Thank you. Thank you for clarifying that. Marissa Bell, last question. Marissa Bell? You're muted. Here you go.
So I should put that hand down. Lord knows I had a pickle of a time trying to even put a hand up. I apparently was waving and didn't know that that was what I was doing.
Sorry.
So okay. So it's only a comment that I would make, and that is to both of you, Simran and Lode. The one who doesn't give up is the one who gets there. So I want to encourage both of you to stay strong, to accept that there are down days, but you get up and you keep going. You keep going. Lode, I was very touched by what you said. I studied midwifery at Emory University, and in a class, because I thought I was in graduate school where I could freely speak to facts, I said, we are failing the Black population of Georgia. I had no idea about these numbers. Blacks are dying like flies in this state. Black women are dying from lack of basic care. And I was told that I can't speak to a professor like that. And so every effort was made that I fail. I was kicked out of the graduate program when I only had one course left to complete in order to become a midwife and sit for the national exam. I decided to go to other schools, and those schools, one of them said to me, please never mention this to anybody, but you're being blacklisted. You will never get into a school in the United States, even though you have a 3.8. You can't get into any other school. And so I ended up going to the midwifery school in Puerto Rico. I graduated from there, and then I started working for Johns Hopkins. So what I want to say to Lode is, or to everybody who was listening to Lode, you have no idea how horrible the situation is in Georgia. We think if we word it correctly, if we do this or that, maybe we can get through. This is so ingrained in the cellular structure of people that it is a battle that has to be fought on many fronts. How offensive or difficult it is, we are taking lives and wasting them with the positions that are being taken. And so I thank you for the work that you're doing in Georgia. You seem so gentle and kind. I want to listen to you. And I hope you get there. And I want Simran to graduate and become the compassionate physician that you were meant to be. Thank you very much.
Thank you.
Thanks, Marisa Bell. I think that's a great way to thank Lode and Simran for being with us today. We're so grateful. I know that for myself, it's been a wonderful, as always, learning experience. Very touched, and look forward to working with you, Lode, down the road with Andrea and Center for Common Ground. Thank you for being with us today. You're awesome. You're amazing. And Simran, absolutely same thing. So at this point, let's just applause from folks a little bit, and then let's pivot to Barbara Pearson for a brief update on the state of our states, which is really a prep for our upcoming Healthcare Now conference that we're going to be doing. But again, Lode and Simran, thank you so much for being with us today. You've really helped to inform us.
Okay, can I share my screen? Oops.
Sure,
wait,
Barbara. Yep, go ahead.
Okay, so this is just very abbreviated. Let me try to make this again. Can you see my screen?
Yeah.
Okay, so basically I have 4 slides. This is the, I hope that when you go to our website, at the top, across the top, it says this, that, and the other thing, and then it says state. And there's a map that you can access. I'm actually have a little kid trying to get us back to our old color scheme, which I liked better. But anyway, I've been working on updating now with the new session, but we still have, now that the federal bills are so iffy for this year, the progress at the states is even more important. So we have these 12 states that have bills. I'm not sure about Michigan. I can't find it. And oops, I didn't want to go there. And when I say Libby, when I say Montana, they don't have a bill, a legislative bill, but they have that little loophole where they were granted, where one town with an environmental disaster was granted Medicare for all for anybody regardless of age, Medicare using automatically. There are other states, and there again, I'm hoping that somebody will jump in. For example, Ohio. I have heard that Ohio does have a bill, but when I look at it, I can't find one with any sponsors that are currently in the Congress. So these states have had them in the past and could have them again. Colorado, Hawaii, Iowa, Maryland, Ohio, Pennsylvania also had a bill, but I haven't been able to find it. Luckily, some people actually respond to my emails. So I noticed that we do have some people here from Ohio. I would love to hear from you. Anyway, there were some states using a ballot initiative. About 16 to 18 states have the opportunity to bypass the legislative route, but both of them have stalled. And I know in other states where they were thinking of doing it, like Florida, they have made it prohibitively expensive to do it. They've upped the numbers. We are working on regional efforts. I forgot to put mine in there, but there's been one going for the West Coast, and I have to change this. And there's also PNHP and the League and OPS have been working on a project for the New England states. So, and we've got quite a number of supporters there. Chuck already mentioned the work that they're doing with the legislative support for HR 3775, or what we'll learn soon what it is. And did you mention, I don't remember whether you mentioned that we're also looking for a senator. So these are the ones that I remember, Elizabeth Warren, mine, and Bob's. Tammy Baldwin, I think, is still a possibility. And something about ERISA with Ron Wyden of Oregon. And that is our committee. One of the things about the limitations of the state initiatives is that not all of the bills are created equal. And in Kip Sullivan's words, some of them are not true single payer bills. Some allow for accountable care organizations, HMOs and so forth, and other progressive innovations. And they have problems around other kinds of things. And some are study bills and not actually bills, but I think they are the study bills in Oregon and Washington, from what I understand, are in fact leading to bills. Anyway, there is, of course, significant opposition to state-based work within the single payer movement, despite our agnostic approach that we favor whatever single payer we can get. But anyway, can I go back to the map and ask if there are any questions?
Looks like, yeah, thanks, Barbara. That was brilliant. And you're already prepped for our Healthcare Now conference, which is coming up. We're going to do a recording the week of April 10th, and then they'll roll it out the week of April 17th. Tom,
great.
since I see Tom's hand is up.
Okay, real quick. Yeah, well, maybe you all know that we now have access to healthcare as a constitutional right in Oregon. That's beyond a study, right, in our Constitution. And the other item is the bill that's currently there, SB 704, is not a study bill. It actually creates the Universal Health Care Plan Board.
Okay, and I think Mike told me that he has passed the baton to you to fill in the Google Doc that you guys made.
I did. I sent Mike a draft. I sent Mike a redraft. So thank you.
Okay. Well, if he'll get it to me, great.
Yeah. Thank you so much for this effort.
And Catherine, you too, you want to correct me there? I'm happy to have others hear you.
Well, I just wanted to say, don't we kind of need to have a frame of mind that actually until we get the state-based Universal Healthcare Act passed federally, no state can really implement a true single payer healthcare system.
Well, some of the states, like New York, says that they have planned it, whether or not they get the Medicare. I don't see how you can do it, but
it has to be a transitional thing. It can't start as until we get that bill.
Well, hopefully we're going to get it. Okay.
True, but I don't think we need to.
So
wait.
I should put that. I should put that. What do you mean we can't wait?
Well, I don't think we can use it as an excuse to say we have to wait until we get it, but no state can start it with a truly single payer bill. It would have to be something that is transitional.
And some of them also have in their word, well, as I said, New York seems to claim that they can do it without having such a bill. But many of the others say have in their wording, this is what we want, and it triggers when that bill passes. So you can get it. Okay. Thank you. I'll be keeping that in mind for when we do this for real. Lode, I'd love to hear from you. I adore midwifery. I think that's such a solution for us.
Yes, I wanted to address that. The other reason why I maintain reproductive justice in the language is because it is a violation of our human rights, is a violation of our reproductive rights. So it's not just the care, because when we say, care or any change to that type of language, then we're able to, again, bypass the weight of what's being affected. So we are violating human rights for any person that wishes to have children. And that, that covers men, women, transgender whomever wishes to have a child, it is their right to have a child. It is their right to choose not to have a child. And we have rights to our bodily autonomy. All of that is covered in reproductive justice. I also I saw Betty had a comment asking to move, give an example away from language, but more so on the resolve. Another issue, one way to be more effective is to get up with or link up with or partner with grassroots organizations and do the work prior to waiting for the bills to pass. So we have now a birth equity fund. More and more families are choosing to have home birth because home birth is safe birth. We have higher positive birth outcomes in home birth versus hospital births. So with all of these hospitals closing down, and if you did not know, Georgia has 159 counties, 82 of them do not have OBGYNs. 75 of Georgia's 102 hospitals do not have labor and delivery units. So you have areas in this state in present day where if you are pregnant, your provider is 45 minutes to an hour away. What does that look like for childbirth? Especially if we've had 12 hospitals close in this state of Georgia. Again, if you have 102 hospitals, 12 of them have closed. So now you're putting more weight on the hospitals that were already understaffed, that already lacked resources, and now you're putting more patients on them. So again, moving to more grassroots efforts of raising funds on your own to do the work until the legislation gets it right.
Thank you.
Thanks, Lode. Let's see, Mark and Lynn, and we should probably put a wrap on the session today after Lynn. A brief comment, question, Mark, and then Lynn.
Yes, just quick. And if there's not a simple answer, don't hesitate, excuse me, to tell me. You had a line on a slide that indicated that there was significant opposition in the single payer movement to state-based plans. Can you give me just a quick answer as to what as to what the basis for that opposition is?
From my understanding, for example, someone like Kate Tillow, whom I adore and think is wonderful, she's very opposed to it. Medicare for All, March for Medicare for All goes on and on. What they don't want to see is 52 different they don't want to see 52 different plans competing with each other and have all the state. I mean, that's not the way the states that are working on this are not thinking of it in that way. And in fact, in New England, we're thinking of a way to make all of our bills compatible so that they have interconnection and so forth. But it's very strong. Some people, another argument I've heard is that it distracts from the push for the national one. And the other is that it's unjust, so that the states that can do it will have better health care and better outcomes, and the states that can't will be left in the lurch.
Okay, thank you.
Those are the things I've heard, and there's probably more.
Okay, fine, thank you.
Thanks, Mark. Lynn?
Years ago, OPS had a spreadsheet of all the states that had bills with the contact person, the number of the bill and stuff. I'd like to propose that we create one and that we have a representative from every state that is working on this. We have quite a few states here, but they're like Massachusetts. Well, you're Massachusetts, but not every state is. We've got Lloyd Alterman. If we could.
I have that, Lynn, if I could cut you off. We have that. I'm making it pretty for when we have the contact, but I have a contact person. They just don't all get back to me all the time.
For every state?
Well, for every state that has the activity. I don't have somebody in Idaho, for example.
No, that's what I meant. Yeah. Oh,
but
great.
I do have someone in each of the states, and I have their contact information, and I'm updating it as we speak. And I do plan to have that as part of what we have on the on our website, on each of the state things. There's contact names and contact groups for each of the states, right? And so just making sure that they're up to date is part of the issue right now.
Yeah. Thanks.
But no, that I appreciate that you want that because I want to get it to you.
Oh,
Okay.
great. Thanks.
Thanks. Thanks, Lynn. Thanks, Barbara. I see Mike's hand is up, and it's impressive that almost everybody has hung in with us this entire time. We do need donations and support to keep going. I'm traveling the country. I'm just looking to get my expenses covered. Living on a Social Security check. I'm pleading with you, please help. Now, anything you can do, even like $5 a month, would really go a long way to supporting the work that we're doing. So if you can go over to the onepayerstates.org and donate whatever you can, that's a big benefit for the work that we're doing. It's and the other thing for folks who don't know, I'm planning to move back to DC. So we have some boots on the ground when our bill is actually released. The memo, the co-sponsorship memo is circulating. We want to get original co-sponsors. And then when the bill is released, we want to educate folks. So we're going to be doing press briefings and so forth. There's a lot of activity planned here, but we do need the support going forward. So thank you for that. Mike?
Yeah, I would vote for keeping in touch with those who oppose state-based universal health care. And one way to do that is to find a common enemy. And right now it's ACO REACH. And so both the people who are not happy about state-based and those who are all in favor of it come together on this, and that allows us a chance to talk with each other. So in my conversations with Anna Malino, and I hope with Kay Tillow and Susan Rogers, I like to point out that most of our federal legislators were at one time state legislators, and state-based efforts allow us to talk with them in some detail where we have a very hard time reaching our federal legislators. The other is just in the organizing. We have a young man who's doing our social media, Simon Hutton, and he says his peers are despondent. They think that we've done such a bad thing to them with our government that why should they even be involved, especially federal government. But when we think of talking with our state legislators, they can actually go see these people, they can talk with them, they can be assigned to do something, and that can give them hope and activism. So those are two reasons to continue state-based efforts, and not as a distraction or opposition to federal, but as a parallel route to get there.
Right, absolutely. And of course, politics is local. It's so much easier to get people to respond about things in their neighborhoods and in their states. Absolutely. It's wonderful. It's much stronger. Thank you.
Thanks, Barbara. Wonderful.
We all
Mike,
believe you.
I'm sorry, what?
I would say we all agree with him because we're here.
No, it's very powerful, the organizing that we're doing, and One Pair of States is a unique organization, and that we support. I mean, our gold standard, as our good friend David Loud, I see you, David, with your hat there, national single payer is the gold standard. That's what we're working toward. You know, we need to connect with people and make sure that they understand that we are in solidarity with this effort. But we're also understanding this is the frame of how Canada got to single payer through a single province, Saskatchewan, and how our Constitution is designed, even though the Supreme Court seems to be ignoring it and rewriting it every day. But the Constitution it's a federal Constitution where states really are laboratories for experimenting, and most of our reforms have occurred from the municipal and state level before they percolated up. Suffrage rights, child labor, and so forth. So thanks everybody for coming together. We're well past the hour, but it's been a very powerful time. I don't know if Lode is still here, but thank you so much. Simran, amazing. You really enlightened us today so much. So thank you so much, and everybody have a great weekend. Be well, stay in touch.
And both of us in the League of Women Voters are so thrilled to see Simran being active again. And I was on a program with Joey the other day. Anyway, great.
Thank you.
Oh, Lode.
Okay. So it seemed like, Mike, you want to turn the recording down?
Oh, yeah.